Hello, everyone, and welcome to the third webinar of the APDA Connecticut Chapter Educational Webinar Series. My name is Marlene Argianis, and I'm the Chapter Coordinator of the American Parkinson Disease Association Connecticut Chapter. Thank you so much for joining us today. We are extremely grateful to Dr. Michelle Lavallee Dagostine for volunteering her time to present today's topic, Understanding Non-Motor Symptoms in Parkinson's Disease. After some brief announcements, Dr. Dagostine will give her presentation and will be answering your questions in a Q&A session. American Parkinson Disease Association Connecticut Chapter, or APDA-CT for short, is part of the largest grassroots network dedicated to fighting Parkinson's disease and works tirelessly to assist more than 1 million people with Parkinson's disease in the United States live life to the fullest. The APDA Connecticut Chapter offers a variety of services in the state of Connecticut. Please visit our website to explore all that we have to offer. Our website also hosts a vast array of publications, webinars, articles, and information that can help you understand Parkinson's disease. If you are participating from another state, we have chapters and locations throughout the United States, and you can find the contact information on our website as well. APDA Connecticut is available through our helpline, email, as well as via social media outlets. A special thank you to our educational webinar series sponsors. Our gold level sponsors are Abbott and Adamas. Our silver level sponsors, Avi, Acadia, Kiowa Kerwin, Savonian, Supernus, and our bronze level sponsor is Brightview on New Canaan. Please visit their websites for more information about their products and services. Today, we are pleased to have representatives from two of the sponsors provide welcome remarks. From one of our silver sponsors, Savonium, please welcome Cynthia Streeter.
Good afternoon. Can you hear me?
Yes, we can, Cynthia.
Okay, thank you. Good afternoon. Today I'm coming to you from the beautiful states of Connecticut, Massachusetts, and Rhode Island, and I'm deeply humbled to be a longtime supporter of the Connecticut chapter of the APDA, particularly the phenomenal Marlene Argianis. And my closing compliments are to all three educational webinar presenters, Dr. Mayton, Dr. Machado, and Dr. Dagostine. I know today will be wonderful. And again, thank you from Synovion. We're so pleased to be a silver sponsor.
Thank you so much, Cynthia. And now one of our other silver sponsors, Avi. Please welcome Scott Parmalee.
Well, good afternoon, everybody. Thanks, Marlene. My name is Scott Parmalee, and I work for AbbVie. AbbVie is a proud silver sponsor and is always happy to support APDA's Connecticut's webinars. I'm looking forward to today's presentation by Dr. Michelle Dagostine from Hartford Healthcare's Chase Family Movement Disorder Center, and I'll turn it back over to Marlene.
Thank you so much, Scott. And now to begin our presentation, we're delighted to welcome Joe Pagano, a representative from one of our gold sponsors, Abbott, who will introduce our guest speaker, Dr. Michelle Dagostine.
Thank you so much. Hi, my name is Joseph Pagano. I'm with Abbott, and I have the absolute pleasure of introducing our first speaker today. Our first speaker is Dr. Michelle Lavallee Dagostine, who is a movement disorder neurologist at the Hartford Healthcare facilities. Dr. Michelle Lavallee Dagostine is a board certified neurologist who completed 2 fellowships, one at Georgetown University in neurophysiology and movement disorders, and Rochester Institute of Technology. She attended Georgetown School of Medicine and she completed her residency in neurology at Georgetown. She's a member of the Parkinson Study Group, the American Academy of Neurology and Movement Disorder Society, and serves on the board of the APDA right here in Connecticut. She is a pillar of the community. She has been named as one of the top Connecticut's doctors in 2018, 2019, and again in 2020. She has repeatedly been named a Vital's most honored professional, top 1% of on-time physician. She is a very compassionate doctor and has repeatedly received the Patient's Choice Awards. She is a Connecticut native and served in the Parkinson's community here in Connecticut since 2010. She has been extremely involved in clinical trial work and is a member of the Chase Family Movement Disorder Center at Hartford. We are so excited to have Dr. Lavallee Dagostine here with us today. Dr. Lavallee Dagostine, welcome, and thank you so much for joining us.
Thank you, Joe, for that beautiful welcome. Hi, everybody. I think many of you on this call know me, but for those I don't, thanks for joining today. I'm gonna go through these non-motor symptoms in Parkinson's. And the reason I chose this topic, and I know some of you have seen similar presentations recently, I'm going to dive a bit deeper and include things that you haven't seen, including pain and skin and a couple other things. Not only have I really dedicated my career to movement disorders and treating Parkinson's, I actually have a family member with Parkinson's disease. What I see day in and day out, both at home and at work, is that education is power. And when people really are well educated, they can be advocates for themselves. And I think that this is one of the areas that people are so often unfamiliar with, and it can just impact quality of life so much. So with that being said, what we're going to do is go ahead and I'm going to just define what the symptoms of Parkinson's non-motor symptoms are. And then I'm going to try and help you on how to identify them, and then give you some options on treatments for those non-motor symptoms. Okay, so just ask that everyone mute themselves if you can. Okay, so just a little bit of a background of basics, and I'm sure I don't have to tell you this. So Parkinson's disease is actually, it's the most common movement disorder that we see. It affects 1 to 2% of our population over 65, but the average age of onset is actually 58 years old. It's the second most common neurodegenerative condition that we treat as neurologists. And in the time that it takes me to give this presentation, 5 people are going to be diagnosed. Sorry, the slides are, let me go back here. So when we talk about the symptoms of Parkinson's, we talk about premotor, we talk about motor, and we talk about non-motor. Most of you are really familiar with those motor symptoms. That's probably what got you to see a neurologist or to go to your doctor, right? Because you may have had a tremor, or you may have been moving slowly, or had some changes in how you walked, and someone probably paid attention, or you thought, geez, it's getting a lot harder to do something basic. And then, in retrospect, you probably went back and kind of thought, I had lost a sense of smell for quite a while, or, I was talking in my sleep or acting out my dreams, or, geez, I've had this building anxiety, or I've had constipation or sleep problems. So those sort of premotor symptoms. But the non-motor symptoms are just not often well covered. And there are so many that I can't possibly cover them all in one talk. But what I want to just touch on are, I'm going to go through premotor quickly, and then I'm going to go through the non-motor and try and touch on them as much as possible. I have blocked my whole afternoon, so I have plenty of time for questions after. So feel free to stay on as long as you'd like. So those premotor symptoms that we talk about that usually people are really unfamiliar with are the loss of sense of smell. That's one of the first ones. By 15 to 20 years, people are losing their sense of smell. And oftentimes I hear, well, I had an injury, I worked in a chemistry lab, I broke my nose. But a lot of times really it's really the earliest sign. We see this REM behavior disorder. This is where you're talking in your sleep, you're acting out your dreams. And it can be something very mild, to sort of talking a little bit in your sleep, to as complicated as, really acting out very detailed dreams. We've got mood disorders. So I'll have people say, well, I've always been an anxious person, but somehow the anxiety has changed over time, right? We see erectile dysfunction in our male patients, predating disease for a long time. We see terrible constipation that could have been a lifelong problem, and fatigue. We see a lot of fatigue. And then as we sort of move into the motor symptoms, these you all know, right? The tremor, the slowness. So when you hear your doctor say bradykinesia, or you see it on a commercial or something, brady means slow and kinesia means movement, so slow movements. And then when we talk about your tone, like, so when your doctor is moving your arm or your leg and we say, oh, your tone looks fantastic, we don't mean, your tone, your muscle tone, we mean you're not stiff, right? We have balance problems, the postural instability. So when we come behind you and pull backwards and tell you, to resist us, we're checking for the postural stability, your way to sort of stay upright. A lot of times we see stooped posture. And what's interesting is that most people feel like they're standing up straight until a loved one or a friend will say, would you, stand up? And you think, I am standing up, but you've got a little stooped over. We see the shuffling, right, where those feet are shuffling, and it typically starts on one side. So one shoe is catching, or you can hear someone coming down the hall. You can kind of hear that little bit of a scuff. I always tell people, line up your shoes and look at them. One shoe may be really scuffed on one side or worn on one side compared to the other. And then we tend to see decreased arm swing. Micrographia just means small handwriting, right? So it can start off okay and then get small and cramped. And then this lack of facial expression. And that really can be something that happens pretty early. I had a young patient whose young son said, Mommy, why are you so upset? Mommy, why are you mad at me? And really, it was just that she was developing this lack of facial expression. And he picked up on that about a year before she was diagnosed. So that is sort of I love this picture because, see, this iceberg is meant to represent Parkinson's, and it's not my artwork, but the top of it is what's sort of visible on the outside. That's the motor symptoms. That's what initially sort of brings you to the doctor. But those non-motor symptoms, that's what's under the surface. And for my family member, for the patients that I have cared for, some of them longer than I've known my own husband, these are the things that really negatively impact their quality of life. And so that's why it's so important really to learn about them. And there are so many, honestly, each of these topics could be its own talk. And at some point, maybe we'll be able to do something like that. But if I can just touch the surface on them, at least you'll be aware, and then you can, dig in a little bit deeper with your own doctor. So we talk about autonomic dysfunction. That's all the automated things your body does. We're going to get into detail with that. That's blood pressure, that's temperature, that sort of thing, right? Sleep disorders, one of the most common problems we see. Sleep disorders are, and the fatigue can really, really be terrible for people. Gastrointestinal, right? So bloating or feeling full really fast, or the constipation, or, abdominal distension. So those are really important. We're going to talk about that. Neuropsychiatric, so changes in mood, changes in memory. Again, both of those really could be their own topic. And then we talk about dermatological changes. The skin changes are very common. And pain. That's one of the big things that people don't talk about, but is really important to kind of be aware of. And so we'll just dive right in. So with the autonomic symptoms, some of the I've taken just some here. We have, two parts of our autonomic system, right? We have the fight and the flight. And when we look at orthostatic hypotension, it's your blood pressure. So when you go from sitting down to standing up, if you get dizzy, if you feel lightheaded, if your blood pressure drops and your body can't get that pressure back up. And in our patients, this can be really debilitating. And it doesn't have to happen just when you stand up. I'll get into this in a minute. It can actually happen 5 minutes after you stand up. We see a lot of urinary frequency and urinary urgency in our patients. I mean, by virtue of being over 40, we are all going to have a little bit of it, but you can see it to extremes, and it's important to identify that as part of Parkinson's. Paroxysmal sweating, so we see a lot of sweating and difficulty with body temperature in our patients. Hiccups can be something that we see quite a bit of, and a lot of sexual dysfunction, very, very common autonomic things that we see. So let's talk about orthostatic hypotension first. So the definition of it is when you go from sitting to standing. We do this in our office. You know, our medical assistants will take your blood pressure while you're sitting. You can take it laying, sitting, and standing, but we typically take it sitting and then standing. And what happens is you see a drop. That top number drops by more than 20. The bottom number drops by more than 10, and you don't see this increased heart rate, right? Typically, if you have a drop, you know, someone who may not have Parkinson's, you get dehydrated, you're working out in the garden, and you stand up and you go, oh, I'm dizzy, but your heart rate has kind of increased to try and get that blood to your brain. In about 30 to 60% of our people, that doesn't happen. And what that ends up meaning is that your brain is not getting good blood flow. So you can feel really tired. You can actually have pain across the shoulders. You can feel confused. You can have memory problems. You can have people get agitated, right? So there's a lot of different things that go into having this low blood pressure, right? So if you chronically, every time you go from sitting down to standing up, you know, or you're changing positions, your brain is not getting enough blood flow. There's a lot of consequences to that. So it's important to talk to your, your clinician about this. And there's different stages of what we do. First and foremost, none of us drink enough water. You know, I've got my big jug of water here and I'm doing pretty well for the day, but it's not empty. Most people that I see have either difficulty with mobility or, you know, we've got overactive bladder. And so the last thing that they want to do is spend their entire day on the toilet drinking water. So it's trying to find a balance. The other thing people do is that they will try and sip on water all day long. When you have low blood pressure because of Parkinson's, the last thing you want to do is sip on water all day long because it will not work. You have to drink fair size amounts at a time. You have to kind of give yourself a bolus. And so for my people who can do it, a lot of times I'll have them take a bottle of water or a glass of water, put it by the nightstand. And if you're able to, first thing in the morning before your feet hit the floor, if you can, you drink that entire glass of water, right? Because now you're starting the day with this big load, and that's going to help your blood pressure stay maintained. And then I have them sort of schedule. I'm going to have 8 to 16 ounces. Everyone always asks me, how much water do I need to drink? And that number is different. If you're a 300-pound person versus, a 95-pound person, your needs are going to be different. So we always have people try and figure it out based on two things. One is your symptoms. Are you dizzy? And number two is the color of your urine. If your urine is dark, unless you're taking a medication that makes it dark, you're not drinking enough. Salt is another really easy thing as long as your primary care doctor or your cardiologist is okay with it. Many of us have spent our entire lives, right, avoiding salt. And in Parkinson's, especially as the disease progresses, we may need to pull back on some of our blood pressure medications, or you may, if you don't have congestive heart failure or other problems, we may need to add some salt to your diet. You can actually have fun with it. It's not hard to find. And if all you have to do is drink some more water and have some salt, that's a nice fix. Now, again, I sort of mentioned for some people, they've been on these other blood pressure lowering medications for quite some time. And so sometimes those do need to be adjusted down. In some cases, we have to lower your dose of levodopa or change the levodopa to a long-acting form, because as our medication peaks and then crashes, that peak is where we tend to see people have lower blood pressure. So we can play around with doses of medication and timing. For some people, they'll wear compression stockings. It's tricky because for them really to work, they have to be hard to get on. The ones that work the best go all the way up to the middle of your thigh. And most people do not enjoy having thigh-high compression stockings on, particularly in the summertime, when you need them the most, right? Abdominal binders, sort of binders that we wear, those work beautifully, but a lot of people are a little bit resistant to them, but they do, that's a non-medication way to increase the tone and kind of keep that pressure up so your blood can get to your brain. We try and avoid large meals and meals that have a lot of carbohydrates, right? So we don't want to have these sort of peaks and crashes. So we'll have sort of a better balance in your meal and have it more often. At our center, we have a nutritionist who works with us to kind of help people if that's an issue. But for many, many people after a good sized meal, their blood pressure will plummet. There are medications, right? So there's Florinef, there's Midodrine, and there's Droxidopa. Droxidopa is also known as Northera. That's the only medication that actually has been designed from the ground up to work in Parkinson's related blood pressure disorders. And I just had a lovely person who'd been taking care of a long time, who I adore, who is really struggling with this. We tried everything else, and within about a week of starting the Droxidopa, he's up and going, and he's doing great. So it's something, you know, if you're having those problems, again, it has to be coordinated through your physician, and your cardiologist may want to weigh in, but those are real options. Just to note, any of you who are taking any of those medications, because they can raise your blood pressure, you should never take them right before bed unless specifically indicated by your doctor. And if you do, you don't want to lay flat. So your head of your bed needs to be at a 30-degree angle, because along with the low blood pressure, we see when people lay down flat, their blood pressure can actually be high. So it becomes kind of tricky because they lay flat to go to bed and the pressure goes really, really high. Okay, well, now as soon as you stand up to go to the bathroom, it's going to drop really low. But we can manage it. We have a lot of tricks for this. There's a lot of strategies that we can employ. But again, you just kind of need to be aware of it, right? Sweating is another big thing I hear about in the office. And this is not just for women, it's my male patients too. It can be drenching. It can be, you know, I've got to change my pajamas. I am waking up soaked. And we typically see this when medication is wearing off. Now, that's not the only time that we see it, but the most common time is we see it overnight. You know, when medication, you're not typically dosing overnight, but you can see this sort of profound sweating when the medication's wearing off. And that can be that sort of non-motor sign that, ooh, your medications need to be adjusted because you're kind of bottoming out, right? And so for this, I ask my patients if they're able to track when it happens, if you can pay attention, not for long periods of time, but we usually are looking for patterns. I think I drive people crazy. I'm always looking for patterns, because if I can find a pattern, I can tweak your medication regimen, you know, and it's different for every person, but we can oftentimes really improve the sweating, and we can sort of make things a lot more comfortable. The other thing, I know a couple of the questions that had come in, and this is not included in the slide, was about being cold. I do see a ton of this. A lot of times our patients get very, very cold. Part of it is due to not moving as much. You're not getting the blood flow circulation that you typically would have had. So what we really encourage people to do is to drink fluids that are warm. It could be soups, it could be teas, it could be coffee, what have you. But a lot of it has to do with movement and sort of exercising is a really, even if it's sitting in a chair, picking your feet up and down, you don't have to aggressively exercise, but a lot of times being freezing cold, that internal sensation that you just can't get warm, such a common thing that we see in our patients. Hiccups. So a lot of people don't know about this, but the hiccups are really, really common in terms of non-motor symptoms in Parkinson's. And it's really unclear if it's related to this autonomic dysfunction, if it's a structural change, if it has to do with sort of the vagus nerve and the diaphragm, right? And so really up to 20% of people with Parkinson's can have hiccups. You have to rule out other causes because there can be other things that can cause hiccups that would need to be addressed medically. But our dopamine agonists, so when you look at certain medications and the ergotamine therapies, they can make your hiccups worse. So if you're on an agonist and you're having these persistent hiccups, you know, you want to talk to your doctor because we may be able to make some changes and really help you out. That's a very common thing most people don't know about. Sexual dysfunction is another thing that we talk about with people all the time, right? So this is extremely prevalent when we look at women and dissatisfaction. The rates are hovering around 40%. And with men, the rates of dissatisfaction are higher, they're 65%, you know, and we see difficulties with arousal, you know, which can be related to some blood flow issues. We see in the autonomic dysfunction, as I mentioned, we can see arousal without ability to orgasm, which can be very frustrating for people. We can see very low desire, right? So as we have apathy or other mood disorders, there too, we see difficulty with desire. And it's very frustrating for people. And I think a lot of times they don't want to bring it up and talk about it because, it could be considered a sensitive topic, but it's something that really does need to be addressed because, there's things that we can do about it, right? Some of our medications can make the dysfunction worse. Some of our medications can increase desire, but we haven't fixed the ability to achieve, arousal or to achieve an orgasm. And so that can put people in a very difficult position. So we have to identify the area of dysfunction. In our personal clinic, we have someone who does sex therapy for individuals and couples. We are also paired with a urologist who works with our patient population who understands the concerns. Because, it's a complicated issue. There are many times where, people have not been feeling right. They may or may not have been diagnosed with the disorder. And by the time we are able to make them feel better medically speaking, there's been a gap that has, arisen between couples. And what you have to do is get everybody on the same page, right? And there's nothing wrong with talking about that. You want to optimize other health conditions. So if we've got, untreated sleep apnea or diabetes or blood pressure issues, those are things that we want to work on. Optimize mental health, right? We're in the middle of a global pandemic. Most of us have not been living our best lives. That's not leading to the best sexual connections with our partners. Exercise in any form is extremely beneficial for helping reconnect and helping people, feel better and have more energy. Again, we refer to urologists and gynecologists, the behavior therapy, endocrinologist. I can't, tell you how many times I've had someone who the hormone levels were off, and when they were replaced, they had more energy or, sort of a rebalanced, sex drive or desire. And honestly, the most important thing is keeping an open dialogue, right? These are all things you should feel comfortable talking to your doctor about. It's nothing for embarrassment, and it's an important part, if you want it to be, of your health and well-being, and you should feel comfortable to discuss it. Moving on to sleep disorders. This is something, again, we talk about this all the time, and the REM behavior disorders is probably the most common right after just the excessive fatigue during the day. So when you sleep, right, some people have heard of rapid eye movement. That's when you're in your sleep, you're dreaming. What is supposed to happen is that your muscles get sort of shut down as sort of a safety mechanism. You're not supposed to be talking or yelling or moving in your dreams. And for whatever reason, when it comes to our population, that doesn't happen. That can predate your diagnosis by decades. Some people will say, I've done it my whole life. You can have periods where it's very active, where you're having these episodes every night. You could go for months or years without having it. Sometimes stress makes it worse, but we don't always have a clear-cut, stimulus for it to happen. It can be, as I said before, very, very minor, but it can be very traumatic. I've had, people actually fall out of bed, strike their heads, get concussions. It can be very disruptive to your bed partner. So, if you've got, your spouse happens to be sleeping next to you, but they're constantly worried they're going to get hit or you're going to shriek, you are sleeping well, but they are not. And so that's an important thing to kind of discuss with your clinician, because, if it's just sort of minor, talking out a little bit every once in a while, moving around, we're not going to give more medication for it necessarily, right? We try and do less is more when it comes to drugs. But if there's any concern for your safety or well-being or that of your bed partner, if you are a couple that chooses to stay in the same bed together, you should be able to do that, right? And now there are many people who choose to switch rooms, and that's okay. But if you'd like to sleep next to each other, I think it's important to talk to your clinician to see if there is something we can do about it, because we do have treatments. The excessive daytime somnolence, so that's another one we hear about, sort of all the time, where people will say, I am so bone tired. And part of the reason for that is that even though you and your partner could both be sleeping the same amount of time, right? 8 hours, When you have Parkinson's, you are not getting the same quality of sleep as somebody who does not have Parkinson's. If we hook up electrodes to your head and we actually look at your brain waves during your sleep, what we tend to see in Parkinson's is that you're not getting the deep restorative sleep. So think about, you plug your cell phone in and it's not plugged all the way in. So you're getting like a trickle charge. You're not really charging that battery. And for many of our patients, that's what's happening. Part of it is because of the physical symptoms too, right? Because it's difficult to turn in bed. It's hard to turn over. You develop pressure points that are uncomfortable that are going to kind of wake you up. Part of it's because of that urinary frequency. I hear all day long, get up 2, 3, 4 times. I've got some people that wake up every 2 hours. There's no way to charge a battery well and get into deep restorative sleep when you're getting up every 2 to 4 hours. It's so disruptive, right? Sleep deprivation is a method of torture. People will not only be fatigued, they will be depressed or anxious. They will have memory problems. They have loss of coordination. You can have hallucinations. It's those are extreme examples, but sleep is so important. And then the sleep wake cycles can be really messed up, because if you're waking up all night long, I've got a number of people who will say, well, I go back to bed finally at 6 a.m., but maybe I can sleep until 11, right? Or they're sleeping until 10. And now you're kind of up, but you can almost reverse when you're supposed to be asleep versus when you're awake. And now you're this night owl up until 2, but you're sleeping most of the day. And if you look at the package insert on every single medication that we have, every single one of them will tell you that fatigue is a potential side effect. Every single one. So it's really, really tricky to help improve the daytime fatigue, but we have to screen for it, right? We have to ask you about it. A lot of times we will recommend a sleep study to make sure that you don't have sleep apnea. You don't have to have someone with a big neck or a big guy or someone who's necessarily snoring to have sleep apnea, especially in women. At the time of menopause, the hormones change. The tone in the muscles in your neck actually loosens up a little bit. Women notoriously are underdiagnosed with sleep apnea because one of the most common symptoms can be fatigue and anxiety, right? And our bed partners tend to sleep through when we snore. So, we might send you for a sleep study. We might try changing your medications during the day. So again, instead of maybe having just a short acting drug, maybe we're going to do something that's a little longer acting, right? Because we want people to, we don't want that peak, right? Because at the peak of the dose, you're probably going to be the most tired. Maybe we're going to switch something to a once a day medication, okay, that you can just take at bedtime. And that way, if you are having sleepiness as a side effect from it, you can sleep right through it, right? So there's a lot of strategies we can use there. We also, and especially in my office, we check your thyroid, we check for anemia, we check your vitamin levels, because sometimes it's, you're anemic, or you're missing a certain vitamin, your testosterone's low, whatever the reason may be. Now, your primary care doctor may be the one who goes ahead and replenishes those things, but it's worth checking. Screening for depression. Depression and Parkinson's we'll get into a little bit later, but it's very different than the depression most of us kind of have the concept of in our brains. Especially during the pandemic, we've seen so much of this. And being tired, being exhausted, losing that drive, having that apathy. So that's something that, oftentimes we really can help with. And then sometimes we use stimulants, right? Easiest thing to add is a little caffeine, or, in the form of coffee or green tea. But sometimes if you don't have cardiac problems, we'll go ahead and add, some stimulants that are on the market, and those can work really nicely for people. You just have to be the right candidate. And then when we move into, we're sort of moving down here, moving into the gastrointestinal system, and again, we'll address each of these separately. We're looking at sialorrhea or drooling. Drooling is very common. Difficulty swallowing, right? Constipation. And then these sort of slowed movements, nausea, bloating, swelling. So when we talk about drooling, really 75% of people with Parkinson's will have excessive drooling. And it typically starts off at nighttime. You wake up with a wet pillow, and it's not that big of a deal. But at some point, for some people, it happens during the daytime, and it can be very embarrassing. You know, my patients are proud, dignified people, and it doesn't feel good to have to carry a handkerchief or to lean forward, God forbid, and have, you know, drool come out of your mouth. We really think it's related to decrease in swallowing, really, than overproduction of saliva. So some of the ways that we manage it early on are with sugar-free hard candies or sugar-free gum. I'm not a big gum chewer, but you know, that can help. But the sugar-free hard candies, just so your dentist doesn't hate us, encourages you to swallow, right? Because you've got this candy in your mouth. The next step usually is there are these eye drops that ophthalmologists use, but we can actually use them under the tongue in small quantities so that, you know, let's say that it's not that big of a problem, but you know, COVID's over, you're going out, you're going to be with a group of people, and you know, you don't want to drool. You could use those drops just at that time and get some better control. You know, you don't want to be too dry, because then the bacteria in your mouth and your teeth will overgrow. Your dentist will hate us, but you know, we're trying to strike that balance. Glycopyrrolate is a medication that can be taken. I don't love, some people will use the scopolamine patches that go behind the ear. You're probably familiar with them with motion sickness. I don't love those because I see a lot of side effects from those. My preference typically are those eye drops and then Botox, botulinum toxin injections. We actually inject just 4 little pokes into the one into each parotid gland and 1 into each submandibular gland. It lasts for about 6 weeks, and then it wears off about the 3-month mark, but I have some people that do it every 6 months. And then we look at this gastroparesis and this nausea. What's really, really interesting is that, so the stomach is not emptying as quickly. And that has a lot of implications for our treatment. Most of our medications are pills that we're taking, unless you have Duopa, right, that gel form that bypasses the stomach. And so we know that if you have this slow emptying in your stomach, you have this slow transit, the food's not moving through as quickly. And you can actually see changes in the bacteria of the gut, the microbiome. And my colleague, Dr. Machado, has a nice talk about this. But you can also see this bloating and distension. And when your medication wears off, it can be much, much worse. And so what we recommend is that you do these sort of smaller, more frequent meals, high in natural fibers. And I want to really point out to you, I'm not talking Metamucil. Metamucil or synthetic fibers really negatively impact the Parkinson's system. In other people who have constipation, they may work quite well, but in your system, they actually make the situation worse. So you want to do, you can do probiotics. You can do plenty of water. Water is number one. If you don't put enough water in, nothing's going to come out. And the water, again, has to be taken in that bolus, not the sips. The sips are great, but if you're trying to move your bowels, that bolus is actually more important. And then we use Miralax every day, and it's every day, or prunes, or dried apricots, or prune juice. It's really important to do it every day, because what we hear all the time is, well, I wait until I get constipated and then I take my medications. And the problem with that is that it's almost like a pendulum. Our bodies don't like that. You have hard stool, okay? And then your body's going to try and get it out, and it's going to pull all the water and try and flush it out. So you can get the stool out, but now you've got diarrhea. Right. And so then you have diarrhea for days and days and days. And now you're so dehydrated and so dried out that now you're going to form hard stool again. So it really does take about 4 to 6 weeks of a specific regimen to get to where, you've got this good bowel regimen, you're moving your bowels regularly. Now I'm going to talk about neuropsychiatric symptoms. I know this is a long talk, bear with me. I'm still going to be mentioning skin conditions and pain a little bit later. I think those don't get covered many other places, so hang in there or take a stretch if you need to. But here we're talking about cognitive impairments, so changes in memory, depression and anxiety, impulse control problems, and then some psychosis. So depression and anxiety, we sort of talked about this, but about 40% of people will report it, and it doesn't matter how old you are, how long you've had the disease, how severe the disease is. So you could be, 3 years in doing very, very well. But the bottom line is that dopamine is a feel-good chemical. And in Parkinson's, we're not making enough. But we're also not making enough serotonin. We're also not making enough noradrenaline. So when people typically think of depression or anxiety, they think it's something they can work through. They think if I just work harder, if I exercise or sleep a little bit better, or if I do the work, if I suck it up, I hear that all the time, I will feel better. Now, those of you who know me, you know I'm very short. No more could I be 6 feet tall than you could suck it up and make more of these chemicals. It's not possible, right? We do things to try and help you with it, but a lot of times, I mean, I will tell you, and especially in the pandemic, you know, people need a little bit of help. And so you can do it with medications that help you from breaking down dopamine. You can do it with medications that help you from breaking down serotonin or noradrenaline. Psychotherapy is great. Being able to talk to somebody who is not your spouse or who is not a friend, who you can really open up to, you know, that can be very, very helpful. We have social workers here in our office, and we do a lot of work with people on this. Exercise, of course, is very helpful, right? Optimizing your sleep is very, very helpful. But, you know, if you had, I always say this to people, if you had diabetes, right, and your pancreas wasn't making insulin, you would never say to yourself, work harder. You know, you would never say, well, if I just worked harder, I'd make more insulin. You know, it's a chemical your body's not making enough. There are more sort of advanced therapies with transcranial magnetic stimulation, which has been approved, and for electroconvulsive therapy in severe cases. And people kind of shy away from those, but they work really, really well. And if you are, you know, 70 years old with well-controlled Parkinson's, but man, you are depressed or anxious, you know, it's really going to negatively impact your quality of life. And so we try and be pretty aggressive about it here, because you know, what good is it if you know, you're moving well, but you're not feeling well, right? You're not going to get out. You're not going to enjoy what you got. Psychosis is something we ask about at every visit. And about 50% of people will experience this at some point. Now, let me be clear. I know that there were commercials that came out a couple of years ago that scared the daylights out of people, my family member included. When we talk about visual hallucinations, so seeing something, okay, that's not there while you're wide awake, typically it's a shadow, or it's something moving in the periphery, or, you know, you look out your window and it's what's that in the bushes. But for some people, it's more. And a lot of times patients don't want to tell you, or your family member won't want to tell you, because they don't want you to think they're crazy. Nobody wants to say, hey, I'm seeing things that are not there, right? But we have to tell each other when these things are happening, because you know, early on, they can be very easy to manage, right? We can make some changes that make it so that they're not going to get significantly worse over time. You know, 10 years ago, the only thing that we had was you know, these atypical antipsychotics. And, you know, we were sort of balancing, are we going to give up some of our motor function, or are we not going to see things, right? Or am I going to lower my dose of medication, but now I'm not going to be able to move as well, right? It's like Sophie's choice. It's a terrible thing to do. We have medication now, you know, Nuplazid or pimavanserin, which you don't have to do that. And I know people get a little bit nervous with these medications, but for the right person, you know, it works on the serotonin system. It was developed for Parkinson's patients. I was involved with these clinical trials for a long time. I've got no financial interest in the drug. But we know now that if we start treating these early, people do better. So, you know, back at Georgetown over a decade ago, you know, if you were having little hallucinations and they kind of didn't bother you, we left them alone because we didn't have a choice, right? It was always risk versus benefit. But we know that the natural course is that if we don't sort of nip it early, you're going to do worse. And so you're much, much better off telling us, you know, I'm starting to see something, so we can address it and be aggressive, right? And again, here it comes back to sleep, and we come back to mood and all these things. But, you know, with the disease, even if you took 0 medications for Parkinson's, even if you are nothing, if you have the disease for 50 years, there is a very good chance that you're going to see something. One of the big times we see this play out is when someone's really dehydrated, if they have an infection, if they're constipated. We see it a lot after surgeries. If you've had any narcotics, really, really common. So temporary, But these are things you really want to make sure that the members of your team are aware of, because we can really, really help with this, right? Get asked a lot of times about skin changes. So one of the most common things we see is this seborrheic dermatitis. And I was trying to show some pictures on different skin types here. There are these sharply demarcated, these red patches and these plaques, like a greasy type of a scale. You see it around sweat glands, right? We see them a lot in the scalp, in the face, right along the hairline, in the eyebrows, the folds here of the trunk. And most of it we see in the face. We see a lot in the face. And again, you know, I just want to show you some more pictures of it because it looks different on different people. But people will say, oh, I have a lot of dandruff, or my skin is really, really itchy. You know, these are things that we see very, very commonly in our patient population, and it is treatable, right? We have a dermatologist upstairs who works with us who can help. Most people have a dermatologist who they work with. What I want to also make you aware of, and we're coming to an end, I promise, is that melanoma, there's a higher risk of melanoma in people with Parkinson's, and it is not related to medication use. It's a known thing that happens in our patient population. We recommend that you get a skin audit once a year. It doesn't have to be anything special, but it's just that skin check from head to toe. I tell my patients, if you didn't flush, they didn't check everywhere they need to. They've got to check between your toes. They've got to check all the places. But it's really important because this is one of those things that if they catch it early, people do very, very well. Okay, this is the last topic. I know this has been a long talk. Pain. I get a lot of people who come in and they have a lot of questions about pain. So the literature really describes, it's a wide range of like 68 to 95% will have pain. Women tend to have a little bit more of it than men, and it really gets broken down into 4 different categories. So musculoskeletal, I'm going to talk about all of these, dystonic, neuropathic, and then central. So when we talk about musculoskeletal, this is probably one of the most common that I see. And so people will have tight muscles, right? You know, one side is typically worse than the other. You've got these really tight muscles and you've got them across joints that have arthritis. And so it can be so painful. It's not uncommon for us to see people come in with knee replacements, or a rotator cuff, a tear or a repair on the side where their Parkinson's is. And I can't tell you the number of times I've seen someone come in and go, I developed Parkinson's after my surgery, but really what was going on is that muscle was really tight, that parking brake was on, and you tore it, right? And so the surgery didn't cause it. The Parkinson's actually caused the need for the surgery. So this is one of the most common things we see. We see hip pain, I see back pain, and if your pain gets dramatically worse as your medications are wearing off, it should be a big red flag for you and for your provider, for your doctor, to try and make some adjustments, right? Because we do see this happen pretty frequently. The dystonic pain is different. So the picture up on the right, you see this gentleman whose foot is sort of turning in. One of the most common things we see are people whose toes are curling, right? It can be when they're walking, but it can happen anytime of night. The toes are curling under, or when they're walking, the leg is kind of pulling, the foot's pulling in or pushing down. We see a lot of cervical dystonia where the neck can be tilted or turned to the side. It's really painful and it hurts. These have to do with the levels of dopamine. These can be treated either by adjusting doses of medication with aggressive, physical therapies, or with Botox, the botulinum toxin. You should not start with a brace. If you put someone's foot, as we see here, in a brace, you're going to get skin breakdown and infections that aren't going to heal because you're not actually treating the problem. If we are going to do bracing, we work together with our physiatry colleagues, where we will do the Botox injections to loosen the muscles, and then they might do a brace, but it's sort of a stage thing. But you don't want to just throw this into a brace because you're going to have a poor outcome. The next type of pain that we see quite a bit is neuropathic pain, right? And so it's more prevalent as you get older. But And it can be from things like diabetes being very common, but in Parkinson's, we do tend to see quite a bit of sort of numbness and tingling, or you can have burning. Tends to start in the feet and sort of work its way up. We always check for reversible causes to see, is it a vitamin deficiency? Is it, is something being pinched? We look for structural causes, and we do have ways to treat it. So if you're having neuropathic pain, we do check certain vitamin levels in our patients at least once a year. So that's important to tell your doctor, because, if you're already having stiffness and you're already having slowness and it's difficult to walk, the last thing you want is to be having pain in your feet, right? That's just going to make it that much harder for you to exercise or do the things that you need to do. And then central pain. This is an interesting one. It's very uncommon, but about 10% of our people will have this. I tend to see it more in the Parkinson's variant, so in the multiple system atrophy type patients, but you can see it in anybody where it's this sort of vague, like a gnawing pain. It's deep and it's aching and it's unrelenting. It can be oral, it can be genital, though those are less common, but it's sort of this deep ache. And it's from inside your brain. It's from inside your brain. So, we do have ways to treat it, but again, you're going to want to share this with us so that if it is something that we can help you with, we can be aggressive about it. Because again, 10% of people is no laughing matter. So again, we have to identify the type. We screen for depression, which can definitely exacerbate chronic pain. It's very, very interesting if you look at the data, and I'm not trying to blame everything on depression, but when people are depressed, their perception of pain changes drastically. Exercise, it's very difficult to ask somebody who has Parkinson's and who's in pain. It's very difficult to ask you to exercise, but we try very, very hard to either do heated pool, exercise, or things that are gentle or in a way that, we're not making your pain worse, because interestingly enough, if you don't exercise, the pain tends to get much worse, right? We adjust your Parkinson's medications. Again, optimizing diabetes, or, someone with a torn meniscus, you want to make sure you don't have orthopedic issues on top of it. We can add medication for pain. I don't like using narcotics in our patient population. I don't think that they work well, but we have other options. And then, we actually do have an integrative medicine team through our centers, and other places do as well, that do massage and acupuncture, guided meditation, the aqua therapy. These are all nice to kind of put together, so that I just want you to know that there are options. Okay, I've covered quite a bit. So hopefully I defined the symptoms. I've helped you identify them, and propose some treatments. And now I want to open it up for questions. And the reason why you keep seeing lotus flowers in my presentation is because the lotus flower every night, retracts and goes down into mud and is sort of reborn every morning. And I find that our patients are just the most amazing, wonderful, resilient, strong people. So to me, this is a symbol of strength. And now I just want to give you an opportunity to ask questions.
Thank you, Dr. Dagostine, for this very informative presentation. To introduce our guest Q&A moderator, please welcome Janet Turcotte, who is a representative from one of our gold sponsors, Adamas. Welcome, Janet. Janet, are you there? Okay. Well, I'm delighted to introduce our guest Q&A moderator, Heather Gray. Heather is the Programs and Research Manager at APDA National Office and has been with the organization for 17 years. Heather works closely with Dr. Rebecca Gilbert, the Chief Scientific Officer at APDA.
Thank you, Marlene. I appreciate that. We have a number of great questions that have already been submitted to us to start off today's discussion. But if you are participating live today and you have a question, please make sure you can put it in the Q&A box on the bottom part of your screen. We're sorry we're not going to be able to get to all the questions today, but we thank you for joining us. So we'll start with one of the first questions we have is there any benefit to medical marijuana like the mints for sleeping?
It's interesting. So it's all anecdotal. I can't point you to any studies. I have a number of patients who do use medical marijuana. and it's interesting. So at the dispensary, they typically will recommend different kinds and different strains. I have some people that absolutely swear by it. I think that the kinds that just have the CBD tend to be a little bit safer from a psychosis standpoint, right, to minimize the risk of hallucinations. But I do have many, many people that swear by it.
Oh, great. Thank you very much for that great answer. As far as constipation, what do you think of taking psyllium husk powder? And that's an ingredient in Metamucil.
Right. So I don't like that in my patients. I mean, this is just my own personal preference. To me, that ends up binding my patients more. My preference is to have people add foods that have a lot of water and are bulky. So watermelon, grapes, strawberries, any kind of fruit. We're coming up on the season. If you do zucchinis or apples or, do you know what I mean, squashes, you want that bulk, right, with the water in it. It's much better for you. Than that husk is really super refined and super absorbent. And the problem is it's like putting lots of little tiny sponges in your intestines. And especially if you're not drinking enough water, you can actually make the situation a lot worse. So I ask people to stay away from that. Great question.
Great, fantastic. Another question that was received prior to the program is weight loss a symptom of Parkinson's disease, and what can be done to help prevent weight loss?
Right, a lot of people will lose motor muscle, and so they will tend to lose quite a bit of weight. So the things that we do is obviously encourage exercise, and not heavy weights, but even 3-pound weights or 2-pound weights, something that you can do to kind of keep your muscle mass up. And then honestly, I use Dr. Secor, who's our nutritionist, all the time. We take a look. I've got a lot of people who really don't have any weight to lose, and they don't have big appetites, right? They get full really quickly. He can, and I'm sure at your centers and your other doctors can do this too. I mean, he can make you a smoothie that has 10,000 calories that most of us couldn't have. But he can do it in a really healthy way so that you're not just getting junk in your system. Adding things like avocados, right, with they're higher in fat, but you've got really good, healthy oils. Doing things like using more olive oil when you're preparing your foods, doing things that are like a salmon that's a higher in fat, but like a healthy fat, right? So you want to mix in foods that are nutrient dense, that are highly caloric, but that are not going to constipate you. A lot of people will go to cheeses and dairy, but that can be counterproductive. So there's a lot of great resources out there about how to do that, but those are the two major things that I'll do for people.
Great, thank you. Another question that we received through registration is, can the cardiac system be affected by Parkinson's disease? Right.
So in our patients that have severe autonomic dysfunction, right, you can see irregular heart rates, right? So it doesn't cause things like congestive heart failure. It doesn't cause things like cardiac blockages, right? So you would never have to have a stent or a bypass, but you can have arrhythmias. Sure, you can have arrhythmias with Parkinson's if you have a lot of autonomic dysfunction. I have a lot of patients who have pacemakers because they've had really, really low heart rates and they're feeling very tired and very run down. And oh my gosh, they're in the ER and their heart rate's down into the 40s. And so that can be something that we do see.
Great, thank you. Another one, someone's asking you to comment on what types of eyesight changes can be expected with Parkinson's disease.
So Parkinson's tends to lead to dry eye, and you can also have watery eyes too, but you can have these sort of dry eyes and light sensitivity. The most common thing we see is double vision because the muscles in the eyes are no different than the muscles in your body. And so one muscle may be affected more than another. So what we tend to see is when people are tired, end of the day, or they're under a lot of stress, they get this double vision. They can kind of find it difficult to focus and they can't see things as well. If it's very consistent, I always send people to a neuro-ophthalmologist so that the person is well-versed in neurology and ophthalmology, because otherwise you might end up getting testing you don't need. Sometimes prisms can be very, very helpful. Sometimes people have got to do the eye drops and things like that.
Oh, fantastic. Thank you. Another question we have live is, what are the recommended doses for probiotics and Miralax?
It's interesting. So for Miralax, it's actually different per person. You know, I have people start with a half of a cap every night, but I've got some people that need a full cap every night. I have some people that if they do that, it's way too much. We kind of start slowly. That's why it really can take 4 to 6 weeks. And you go sort of little by little. The probiotics are a little bit more difficult, and I actually defer that to our integrative medicine doctor, Dr. Secor, because you have to get the right kind. It also depends a lot on what your diet's like and how often you're moving your bowels. So that's a little bit more personalized. That varies per person.
Oh, thank you very much. Can hair loss be caused by PD? That's another question live.
We do see some hair loss. It's interesting. There are certain medications that I have seen over time with a handful of patients with hair loss. I think it has more to do with the changes in the scalp, right? And a dermatologist may say something else, but I find it has to do with the changes in the scalp coupled with a lot of times not enough protein intake. So many of our people, as they move through the disease, are having difficulty absorbing their levodopa, and they're not doing as much good protein. If you don't have the protein, your hair is going to suffer. So whenever we're having that problem, you know, we do an inventory for nutrition, but I also have people see a dermatologist to see if there's something we can do about it.
Great, thank you. Another question we have live is someone wants to know how Tylenol PM mixes with carbidopa levodopa, and is it true that it's not good mix for that?
Yeah, so the way the Tylenol PM works, I mean, the Tylenol in and of itself is not the problem, it's the PM part of it. It's basically Benadryl. So I don't love it when people take that, because Benadryl in older people can cause confusion, hallucinations, weight gain. It can give you kind of that hangover, urinary retention, dry mouth, irregular heart rate. So I don't love that as a go-to. We use a lot of melatonin in our practice. I find that most people don't use a high enough dose. So your typical person without Parkinson's will dose, 1 to 3 milligrams of melatonin. I find that our patients, and there's really good literature supporting it, really need more like 5 to 10 milligrams, and it's got to be every night for at least 2 weeks at the exact same time. But there's literature to support doses up to 50. I don't personally go that high. It does come in a bi-layer, so you can have ones that have a little short acting and a little long acting that you can get over the counter. But I absolutely recommend people to stay away from those like Tylenol PM or using Benadryl for sleep. It's a dirty drug, and over time, it can pose a lot of side effects.
Thank you very much. Another question that we received through registration was, does acupuncture have any effect on Parkinson's disease?
Yeah, I love acupuncture. I'm a big fan, and our doctor here, Dr. Secor, does it. I think it really helps with centering and relaxing people. When people are under stress and you've got Parkinson's, your Parkinson's is going to be worse. So if you can, do acupuncture for pain, or do acupuncture for, stress relief, or do acupuncture for, discomfort. They've got a variety of treatments. It's not magic beans, and none of our things are. But if you put it together with a really good plan, and you're doing some exercise, and you're hydrating yourself, and you're sleeping, I am a big believer in combining all of those therapies so you can have your best quality of life.
Oh, great. Thank you. And also a question live we have is, magnesium good for constipation?
Magnesium is fabulous for constipation. Magnesium citrate, the capsules tend to work better. You have to be a little bit careful because they can be quite effective, but it can actually help you for sleep and muscle cramping and for constipation. You always want to check with your primary care doctor though first to make sure that there's no reason why you shouldn't be taking that.
Oh, fantastic. Thank you so much. Also, another question that came in with registration is there any foods or supplements to reduce symptoms that you recommend?
It's really hard because it depends on the symptom you're talking about. There's a lot of supplements that are geared towards, increasing your levels of dopamine. The problem is that your brain is very much built in a way to keep things out. We have a blood-brain barrier. Things are not supposed to get in. Even the pills that I give you, levodopa, that's designed to get in there, only 1 to 5% of it actually crosses that blood-brain barrier. So, if you're looking to decrease inflammation, things like turmeric, I think are very, very good. Limiting, flours and sugar, I think are very, very helpful. But the majority of the supplements out there just are not going to be effective.
Okay, another question we have live is, what about headaches in Parkinson's disease?
Yeah, so typically we see headaches for a couple reasons in Parkinson's. I would say the most common is because of cervical dystonia. So when the neck is really tight and the muscles are sort of pulling, it's gonna turn into a tension headache or a headache. And so the way to treat that really is through managing the cervical dystonia. The other big thing that I see with, well, two other things I see with is dehydration, which is a terrible, terribly common and can cause headaches. But also when we have the vision changes, the double vision, if the vision's off a little bit, not enough to be really super noticeable, a lot of times what you'll see is that people are getting headaches when they're trying to focus on something. And so that's, again, where we look at those prism glasses or trying to make those adjustments.
Thank you. You're giving out very helpful tips and tricks for people today. I appreciate that. I think we have time for one more question, and that is, live, can hypnosis help with sleep?
That's a great question. You know, I work with Dr. Bob Deutsch, who's up in West Hartford. He does hypnosis, and for the right person, it can be very helpful. What I find the most challenging with sleep, and you know, and I hear this from my sleep colleagues over and over again, is that most of us have very, very poor sleep hygiene, right? We have sort of trained ourselves like you would train an animal to do all these things wrong, right? And so when it comes to sleep, our bodies have to be sort of, and this is where the hypnosis comes in, you have to really train your brain to associate certain things with sleep, right? So that maintaining a schedule is more important than I can tell you, right? So let's pick a time, let's say 10 o'clock. Let's say, so every night, you know, at 9 o'clock, you know, your bed's at 10. If you're someone who takes melatonin, you take it at 9 o'clock. You're not watching programs that are upsetting, right? So you're not watching, you know, war movies or something that's gonna be frustrating. The light in your space should be kind of turned down, right? You don't want bright lights. You don't want computer screens with, right, these blue full spectrum lights in your face, because that tells your brain it's time to get up and start farming. That's very primitive. Your bedroom should be cool, not warm. You really should be kind of on the cool side. It should be dark. It should be boring, right? The only things you should be doing in bed are sleeping and snuggling, and like, that's it. You shouldn't be in bed if it's possible. I know for some people, we do have to go in a bed and be there to do other things. But if you're not one of those people, you know, you shouldn't be reading a book in bed or playing on an iPad in bed or watching war movies in bed. That really needs to be the place that your brain says, okay, I know that this is where I go to sleep. This is where I go to sleep. And if you're laying in bed more than 20 minutes and you're solving the problems of the day, you got to get up and get out of your bed and go do something very boring. Pull out a book if you can, a magazine, but you don't want to, again, turn on the television, get on the computer, because now you're secreting all these hormones that tell you it's time to wake up, and it's very confusing for your body. You know, you want to minimize caffeine so you're not doing that afternoon, and not do a heavy meal at bedtime. And then exercise, ideally, if you're someone who has a problem with sleep, should be done really before around 1 o'clock in the afternoon. I think the hypnosis helps you because it helps sort of train you to relax and unwind, but you can do the same thing with deep breathing. And there's all these apps that you can do now to kind of unwind you and sort of relax. But it's more honestly about building this routine. Just like, you know, you get in your car and you put on the seatbelt, you don't even have to think about it. If you can make it automatic, and it takes 3 to 6 months, but you know, it's worth it. If you've got 30, 40, 50, 60 years to live, it's worth investing the time to do it right, because once you get into that good habit, it will pay off in dividends. I can always tell who's sleeping well in my patients.
Thank you so much, Dr. Dagostine. I wanted to know if there was anything you would like to add before we conclude this session.
I just want to thank everyone for joining. Fabulous comments. I love answering questions. I love what I do. I love all my people, all my patients that are out there. If you're listening, big hugs. But just stay safe and enjoy the nice weather.
Thank you so much. And I'm going to now pass it back to Marlene. Thank you again.
Thank you, Heather, for being our guest moderator for the Q&A session. And thank you so much, Dr. Dagostine, for such a wonderful presentation.
Okay.
For additional information, answers to your questions, and resources, please visit our website. You can also email or call us via the email and phone number on the screen. Please save the date for our annual educational symposium. Unfortunately, due to COVID this year, the event will be virtual. I'm sorry about that. But we look forward to a very informative week of presentations on various topics related to Parkinson's disease. The week-long event will take place from April 26th through April 30th, every day at 2 p.m. Eastern Standard Time. Additional information and registration are up on our website. If you enjoyed today's webinar, we hope you will consider supporting APDA Connecticut with a donation. With your help, APDA Connecticut can deliver more programs and services like this one, which are needed now more than ever during these challenging times. On behalf of the entire APDA Connecticut chapter, many thanks to Dr. Michelle Dagostine, Heather Gray, all of our participants, and our sponsors. Abbott, Adamus, Abby, Acadia, Kiowa Curran, Savonian, Supernus, and Brightview on New Canaan for supporting our program. If you know someone who missed today's program, if you joined late, or you would simply like to watch again, you can view a recording on our website at apdaparkinson.org/CT within the next day or two. Thank you all and have a wonderful afternoon.